Hi, my name is Usama Naga. We'll start the first part of infectious diseases. You can follow with me in the Pediatric Board Study Guide, Infectious Diseases chapter from page 195 to page 198. We'll start with antibiotics. Classification of antibiotics: bactericidal, bacteriostatic. Bactericidal kill bacteria directly. Bacteriostatic, they limit the growth of bacteria, or they inhibit the growth of bacteria by interfering with DNA replication, protein production, or other mechanisms. At the end, you will have arrest of growth of bacteria. They must have immune system function. They must work together with the immune system in order to remove the bacteria from the body. Examples of bactericidal: penicillin, aminoglycosides. Examples of bacteriostatic: erythromycin or macrolides and tetracyclines. Very important to know that low concentration of bactericidal can be bacteriostatic, and the high concentration of bacteriostatic can be bactericidal. Also, some antibiotics, they are bactericidal for certain organisms and they are bacteriostatic for other organisms. Mechanism of action of antibiotics. Some antibiotics, they inhibit the cell wall synthesis. Examples of that: penicillins, the cephalosporins, the carbapenems, monobactams, vancomycin. Some antibiotics, they inhibit the protein synthesis. You know that the protein synthesis is by the ribosomes. So some antibiotics, they inhibit the 50S subunit of ribosomes, like macrolides, clindamycin, linezolid. Some antibiotics, they inhibit the 30S subunit of ribosomes. This way they will inhibit the protein synthesis. Examples of that: aminoglycosides or tetracycline. Some antibiotics, they inhibit nucleic acid synthesis or function. Example of the antibiotic inhibit the folate synthesis is trimethoprim, sulfamethoxazole, or Bactrim. Other antibiotics, they inhibit DNA gyrase, which is very important for DNA replication and uncoiling. For example, quinolones like ciprofloxacin, nalidixic acid. Antibiotics, they are reduced and they produce free radicals like metronidazole. That's why metronidazole need to be reduced, so it works only in obligate anaerobe bacteria. This is just an overview of the classification of mechanism of action of antibiotics. Let's start with aminoglycosides. Examples: gentamicin. Gentamicin is a very important medication. We use it all the time, especially in NICU for neonatal sepsis, and the common song AMB and gent. AMB to cover for gram-positive bacteria like group B streptococci and listeria, and gentamicin to cover for gram-negative like E. coli. Very important to know everything about gentamicin. Gentamicin also is an excellent eye drops for bacterial conjunctivitis, and tubramycin as well. Tubramycin and the amikacin also can be used in the IV form for resistant bacteria like Pseudomonas or Serratia. Streptomycin commonly used in cases of tuberculosis. All aminoglycosides, they inhibit bacterial protein synthesis by binding to bacterial subunit 30S ribosome. Very important to know. Drug activity against aerobic gram-negative bacteria is an excellent medicine against the gram-negative organisms. E. coli, Yersinia pestis, or plague Francisella tularensis, which is commonly seen in cases of hunters where they do skinning of rabbits, for example, and will cause tularemia. It has some activities also against staphylococcal species, Mycobacterium, Entamoeba histolytica, Cryptosporidium. Very important to know the drug toxicity of aminoglycosides. Nephrotoxicity and ototoxicity can cause renal impairment and hearing impairment. Very important to monitor the level to prevent these complications. Very important also to know the common uses of aminoglycosides. In neonatal sepsis, as we mentioned before, AMB and gent to cover for suspected sepsis in neonates. Bacterial endocarditis, very important, the gentamicin to be used in the first 2 weeks in most of the cases of bacterial endocarditis. Tuberculosis like streptomycin also can be used in intra-abdominal infection or complicated intra-abdominal infections. It has also some coverage for anaerobes, not just aerobe. Complicated urinary tract infections or pyelonephritis, nosocomial respiratory tract infections, and the plague. Also, as we mentioned before, can be used for topical eye drops like tubramycin and gentamicin for bacterial conjunctivitis. Drug monitoring. I will take gentamicin as an example of aminoglycosides because it's widely used in NICU because of coverage for sepsis. If you are using the medicine for 48 hours only, you don't have to do drug monitoring. If you are using the medicine 5 days or more, you have to do drug monitoring the trough level in order to monitor for toxicity to prevent auto or nephrotoxicity. So we have two levels to understand: trough and peak. What is the trough? Is the lowest point in the curve, the lowest concentration of the medicine. So it makes sense if you are measuring the trough or the optimal or the lowest effective dose of the medicine, you need to test that before the medicine is given, not after. If you want to know the highest concentration of the medicine, you need to test that after the dose is given, usually 30 minutes after the dose is given. So if you want to know the trough level, you do it before the second dose is given, or you will be according to the protocol in your NICU, but commonly is before the second dose of gentamicin. If you do the trough level and the trough level came back more than 2 microgram per ml, this is high, this is toxic. So you need to prolong the interval. For example, if you are giving the medicine every 24, you prolong the interval to every 36 or every 48 hours, or you decrease the dose if the prolonging the interval is not working. For the peak level is used only in few circumstances. So the commonly used now is the trough, not the peak. So if the peak, for example, is low, like for example, you know the ID of the organism and you want to have an excellent concentration in order to kill this organism, so you increase the dose by 25%. But commonly we do not use the peak, we could use the trough to monitor for toxicity. This is just an overview for beta-lactam antibiotics. Then we'll go on each one in detail in the next few slides. We have penicillins, cephalosporins, carbapenems, and monobactam. Penicillins, we have the first three that are natural penicillins. Benzathine penicillin is a long-acting, is IM. Penicillin G is short-acting, IV, and penicillin V is the oral form of natural penicillin. They provide an excellent coverage for gram-positive bacteria, anaerobes, and they are the first line in the treatment of syphilis. They do not cover for staph. Very important to know that natural penicillin, they do not provide coverage for Staphylococcus aureus. Ampicillin, amoxicillin, they cover for gram-positive plus gram-negative with existing resistance against gram-negative. Amoxicillin, ampicillin plus beta-lactamase inhibitors, clavulanic acid, and sulbactam. This is oral, this is IV. They cover for gram-positive, gram-negative anaerobes. Nafcillin, oxacillin, they are anti-staph and they do not cover for MRSA, just MSSA. Piperacillin, ticaracillin, piperacillin, tazobactam, they are anti-pseudomonal. This will known also as zeusin and covers for anaerobes and gram-negative. We have cephalosporins, they are 5 generations. First generations, they cover for gram-positive, especially staphylococcal infection. They cover also for strep. And they cover for E. coli as well. The IV form is cefazolin and cephalexin is the oral form. They do not cover for MRSA. Second generation, they cover for gram-positive plus gram-negative and anaerobes. Cefoxitin or Mofoxin is IV. Cefotitan is IV as well. They are commonly used for surgeries and abdominal surgery because of coverage against anaerobes. Cefoioxime and cefaclor, they are oral forms and they can be used also for community acquired pneumonia. Third generation, they have gram-positive and gram-negative, but more gram-negative coverage. Ceftriaxone, cefotaxime, ceftazidime cover for Pseudomonas. The oral forms are cefobudoxime, cefixime or Soprax, cefdinier or Omnicef. They are oral forms. Fourth generation Cefepime cover the same like first generation and third generation for gram-positive and gram-negative, plus it covers it has or provide coverage against Pseudomonas. Fifth generation is the most recent. Ceftaroline covers against MRSA plus the other coverage as well. Carbapenems is IV. There is no oral form of that and mainly used for surgeries and anaerobes. High level of imipenem can cause seizure. Very important, high yield. Monobactam asterionam, commonly used in the patients that are allergic to penicillins, and if you still need beta-lactam coverage or coverage against gram-negative. Also used for Pseudomonas, but does not work for gram-positive or anaerobes. The first group of beta-lactam antibiotics, penicillin. Penicillins, they kill the bacteria by inhibiting the cell wall synthesis. We have natural penicillins like benzathine penicillin is a long-acting IM, penicillin G is IV or IM, penicillin V is oral. They cover for gram-positive and anaerobes. Long-acting penicillin commonly used in cases of rheumatic fever, monthly treatment, and also can be given one-time treatment for throat infection with group A beta hemolytic streptococci. Penicillin G commonly used in the hospital in IV form, covers for syphilis, meningococcal meningitis, very sick patient with meningococcemia. Penicillin V is an excellent medicine, is the drug of choice for treatment of throat infection with group A beta hemolytic streptococci. Can be given twice or 3 times a day for 10 days. Also, the dentists, they use it all the time because it has an excellent coverage for oral anaerobes for dental infection and dental abscesses. Second group is ampicillin or amoxicillin. Ampicillin is IM IVPO, so can be used in the hospital in IV form. Remember, Ampangin used for a newborn to cover for suspected sepsis. Ampicillin cover for listeria and covers for group B streptococci, and gentamicin will cover for E. coli in cases of a newborn with suspected sepsis. Amoxicillin is the PO form, is easy to use, and commonly we use it for acute otitis media, but in a high dose, 90 mg per kilo per day to cover for resistant bacteria. Also can be used for community acquired pneumonia. Also they can be used for UTI, but the resistance now is existing. So if you are lucky, the E. coli will be susceptible to amoxicillin, but rarely we see it these days. We have here beta-lactam antibiotics, amoxicillin, ampicillin. But in addition to that, you have beta-lactamase inhibitor, clavulanic acid, and sulbactam. They inhibit the beta-lactamase produced by the bacteria to destroy the beta-lactam antibiotic. So they are a stronger antibiotic than amoxicillin or ampicillin by itself. You have amoxicillin clavulanic acid is an oral form well known as Augmentin. Provide an excellent coverage and the treatment for acute otitis media, but you still have to use the high dose 90 mg per kilo per day for 10 days in order to treat acute otitis media successfully. Sinusitis also, you can use the same dose but longer time, like 14 days or 21 days. MSSA, so they cover for Staph aureus but sensitive one, but they do not cover for MRSA. It is the drug of choice. Augmentin is the drug of choice for animal bites. It is a high yield because it covers for Pasteurella multisida and Staph aureus. So you can use it for dog bite, cat bites, animal bites in general, because it covers for Pasteurella multisida and Staph aureus. High yield. Ampicillin sulbactam is IV, commonly used in the hospital, well known as Unicin. Covers for anaerobes, like in case of aspiration pneumonia, lung abscesses. Also cover for animal bites, like if you have severe animal bites and the patient is hospitalized, you can use the IV form ampicillin sulbactam to treat animal bites. Also it can be used for community acquired pneumonia. Penicillinase resistant penicillins like nafcillin or oxacillin, they come in IV form, and they are the drug of choice only for methicillin sensitive Staph aureus. They do not cover for MRSA or MRSA. So they can be used for osteomyelitis in hospitalized patient, meningitis or endocarditis. Anti-pseudomonal penicillins like piperacillin or ticaracillin, the most common combination we use in the hospital is piperacillin and tazobactam. So this combination is well known as Zosyn. It is the drug of choice for Pseudomonas aeruginosa. Why? Because it covers for gram-negative. Pseudomonas is a gram-negative bacteria. Also cover for gram-positive like Staph aureus and anaerobes. So also can be used in cases of complicated appendicitis, like ruptured appendix before and after surgery, and other causes of intra-abdominal abscesses. Also can be used in acute aspiration. Cephalosporins are bactericidal antibiotics. They inhibit the bacterial cell wall synthesis and they kill the bacteria like other beta-lactams. There are 5 generations. The first generation cefazolin IV and the cephalexin PO. They are very strong against the gram-positive bacteria, especially Staphylococcus aureus, MSSA, but they are not used against MRSA or MRSA. So if you have a child with cellulitis, skin infections, soft tissue infections, and you suspect Staphylococcus aureus, the MSSA, not MRSA, you can use cefazolin. If the patient is hospitalized, you can use cephalexin if is outpatient. Second generations, they are the primary use is anaerobes. The most famous one is cefoxitin. It covers for anaerobes and commonly used for surgeries like prophylaxis, like for in cases of appendicitis, you can give 1 dose before surgery and after as well, and generally used for abdominal surgeries prophylaxis because it covers for anaerobes. Also can be used for PID or pelvic inflammatory diseases, is well known as Mefoxin and is IV. Cefotitan also is IM/IV, and we have cefuroxime is PO and cefaclor PO. They are commonly used in treatment of outpatient community acquired pneumonia. They have also some gram-negative activity. The gram-negative activity increased in 3rd generation, and they keep the gram-positive activity. So we have ceftriaxone, cefotaxime. They are commonly used in cases of meningitis. Ceftriaxone is a long half-life and can be used as outpatient in the office. Like if you have a child with acute otitis media and is vomiting, you can use ceftriaxone as 1 dose in order for the child to be able to keep the oral medicine afterward. Ceftazidime is the only one covers for Pseudomonas in 3rd generation. We have oral forms of 3rd generation cefobudaxim and cefixime, which is well known as Suprax, commonly used in cases of UTIs and also used in resistant cases of acute otitis media. Cefdinir is oral medicine also of 3rd generation, commonly used in cases of resistant cases of acute otitis media and pneumonia. So very important to remember, ceftazidime is the only one in 3rd generation covers for Pseudomonas. 4th generation cefepime is IV, is a stronger antibiotic. It has the same strength of 1st generation for gram positive. It has the same strength for gram negative like 3rd generation. Plus it covers for Pseudomonas bacteria. 5th generation is much stronger. Ceftaroline is IV and covers for MRSA. Carbapenems also is a beta-lactam antibiotics. The most common one we use imipenem and usually combined with cilastatin, and is well known as Primaxin. Covers for gram-negative bacteria, especially Bacteroid fragilis, so is commonly used for abdominal surgeries, for abdominal infections, peritonitis, and abscesses. Also covers for gram-positive bacteria like Listeria and Enterococcus fecalis. The last antibiotic we'll discuss in beta-lactams antibiotic is Monobactam. Is well known as Aztreonam. Aztreonam, very interesting, that is one of the type of penicillin or beta-lactam antibiotics, but you are able to use it for the patients who are allergic to penicillin. Also can be used in the patient that cannot tolerate aminoglycoside and at the same time you want to cover for gram-negative bacteria. Very commonly used for Pseudomonas aeruginosa, so can be used for the patients with cystic fibrosis. Actually, it has a form of inhalation and it can be used via inhalation for patients with cystic fibrosis. But very important to know, it doesn't cover for gram-positive and doesn't cover for anaerobes. Clindamycin inhibit the bacterial protein synthesis by binding to the 50S ribosomal subunits, and in this way will kill the bacteria. The coverage of clindamycin, it provide coverage against anaerobes, very important medicine for anaerobes, MRSA or methicillin-resistant Staph aureus, and also provide generally a coverage against staph and streptococcal infection. So is an excellent medicine for gram-positive bacteria. The adverse reaction is diarrhea, including C. difficile enterocolitis. Macrolides are very common, very high yield. They inhibit the protein synthesis in the bacteria by binding to the 50S subunit ribosomes, and they inhibit the growth of the bacteria, and the immune system will clear the bacteria. They are bacteriostatic. We have azithromycin is available now in oral and IV, clarithromycin available in oral, erythromycin available in oral and topical for eye infections. They cover gram-positive like penicillin, and they have limited gram-negative activity coverage, and they cover for Helicobacter pylori, especially clarithromycin. This is what we use all the time for gastric ulcer and gastritis in combination with amoxicillin, clarithromycin, amoxicillin for Helicobacter pylori. The special and unique about macrolides, they cover for atypical bacteria, not like penicillin. They cover for pertussis, mycoplasma, chlamydia. Very important to know that macrolides, all macrolides, they inhibit the cytochrome P450, so there is a lot of drug interactions. So very important to know that azithromycin does not inhibit the cytochrome P450. So all the macrolides, they inhibit the P450 except the azithromycin. Also, you need to know that the macrolides, they are motilin agonist. Macrolides like erythromycin is a motilin agonist and cause or stimulate the intestinal motility. So sometimes they are used for the patient they suffer for hypomotility or gastroparesis. Also, they can cause gastrointestinal irritation like nausea, abdominal pain, vomiting, diarrhea. If they are used in infants less than 1 month, this can cause hypertrophic pyloric stenosis. Very important to know about erythromycin. Topical ointment we use in newborn. This erythromycin ophthalmic ointment is an excellent drug to protect against gonococcal ophthalmia, but does not protect against chlamydia. So when we use it, we are protecting against ocular gonorrhea, not ocular chlamydia. There is no medication exists to protect against or prophylaxis against ocular chlamydia. Rifampin is a bactericidal antibiotic, inhibits DNA-dependent RNA polymerase and kills the bacteria. It is commonly used for treatment of tuberculosis, invasive Haemophilus influenzae bacteria. Indications for rifampin, of course, tuberculosis, close contact to a child who has invasive meningococcal infection. Combination with vancomycin is certain staphylococcal infection like cases of VP Shunt, osteomyelitis or endocarditis. Persistent to group A streptococcal pharyngitis in combination with beta-lactam antibiotics, so for eradication. MRSA carriage eradication attempt. Very important before you prescribe this medicine to let the patient know that it can cause reddish orange body fluids, and even if they have contact lens, it can cause staining of the contact lens and can cause hepatotoxicity. Fluoroquinolones, they are very strong antibiotics. They prevent the bacterial DNA from unwinding and duplications, so they prevent the division of the bacteria and they kill the bacteria. Examples of fluoroquinolones: ciprofloxacin, ofloxacin, levofloxacin, gatafloxacin. The AEP recommendation to use Cipro in children if the pathogen is multi-drug resistant, so is not usually your first choice. You have to use it when there is no other option. If the pathogen is the multi-drug resistant, no safe and other effective alternative, parenteral therapy is not visible, no other effective alternative oral agents. Bacterial coverage: UTI is caused by multi-drug resistant gram-negative rods, like patients they have intermittent catheterization and chronic UTI. Resistant gram-negative rods, Pseudomonas, like in cases of nail in the shoe, this will insert the Pseudomonas in the bone and can cause osteomyelitis. You can use Cipro as outpatient. Chronic or acute osteomyelitis. Tetracycline inhibit the protein synthesis by binding to the subunit 30S of ribosomes in the bacteria. It is active against the tick-borne organisms. It is the first line in the treatment of Rocky Mountain spotted fever, Lyme disease. It is widely used in cases of acne and inhibits the Propionibacterium acne, especially the one is used, the doxycycline and minocycline. It also can provide coverage against MRSA. So it provides coverage against the gram-positive, gram-negative with few exceptions except Pseudomonas and Proteus. It is not recommended to use before 8 years of age. It can cause staining of dental enamels, and tetracycline is usually more than doxycycline for staining of the teeth. It is commonly used in Lyme disease in children more than 8 years old, but can be used in children less than 8 years old in life-threatening situations like Rocky Mountain spotted fever. This is the exception, and this is a high yield. Trimethoprim sulfamethoxazole is a very important antibiotic. It inhibits successive steps in the folate synthesis pathway, and this will inhibit DNA protein synthesis in bacteria and prevent bacterial replication. It provides coverage against gram-positive, gram-negative bacteria. It is a very important antibiotic in the treatment of UTI in children because it covers against E. coli. Even the resistance is increasing, but it's still widely used, it's still effective, and also used for prophylaxis in children with recurrent UTI or high-grade vesico-urethral reflux. Also, it provides coverage against resistant Staph aureus MRSA, and is easy to use, is generic, and can be used as outpatient in these cases. Also provides prophylaxis or treatment against this bacteria, Pneumocystis jirovecii, in immune-compromised patients. Also can be used in case of gastroenteritis because of Salmonella or Shigella. Also covers against Burkholderia cepacia, and this bacteria is common in the patients with cystic fibrosis. It's very unlikely to see it in healthy populations, but you see it commonly in patients with cystic fibrosis. So you can use for that Trimethoprim, sulfamethoxazole. Also covers against Brucella. Rash is a very common adverse reaction of Trimethoprim sulfamethoxazole. Also can cause neutropenia, and severe cases can cause Stevens-Johnson syndrome. Contraindication should not be given to neonates during the first 6 weeks of life. Why? Because the sulfamethoxazole or sulfonamide can displace the bilirubin from its albumin binding sites in the plasma and can cause kernicterus. So very important not to use in the first 2 months of life, usually 2 months and older, but less than that is contraindicated. Vancomycin is a very strong antibiotic. It inhibits the bacterial cell wall synthesis. Very important to know the bacterial coverage and when to use it. Bacterial coverage confirm gram-positive infection in patients seriously ill or allergic to beta-lactam antibiotics. Also is used or commonly used as initial empiric treatment in a child more than 2 months with meningitis in combination with third-generation cephalosporin like ceftriaxone or cefotaxime. Also commonly used in cases of methicillin-resistant staphylococcal infection, MRSA. Prophylaxis before prosthetic device implantation in major surgeries. Orally for C. difficile colitis. Acute infectious endocarditis if Staph aureus is the likely cause. So very important to know when to use it, and do not use it unless it's really necessary or indicated. If you decide to use the vancomycin for your patient, we need to know and be familiar with the side effects and how to manage. You need to know that vancomycin can release the histamine in some patients and can cause redness in the head and neck and the itchiness, and this is well known as red man syndrome. This is related to the infusion rate. So if you slow down the infusion rate, you will manage this case. Then in the next dose, you need to pre-medicate with diphenhydramine or Benadryl. Very important to know that vancomycin can cause nephrotoxicity and ototoxicity, especially if you combine it also with another medication, nephrotoxic, ototoxic like gentamicin. Generally, when you give the vancomycin, you need to follow the trough level and you withdraw the blood 30 minutes before the 5th dose for vancomycin level and adjust the dose accordingly. Very important to know that misuse of vancomycin can cause development of resistance. Very important to know how to monitor the level of vancomycin to prevent ototoxicity and nephrotoxicity by withdrawing the vancomycin level 30 minutes before the 5th dose. And you need to measure the trough level, which is the lowest point in the curve, and adjust the dose accordingly. So by prolonging the interval or decreasing the dose if the trough level is high. So very important to know that peak level is not important and is not necessary to use in case of vancomycin. Usually the trough level is commonly used. We'll start a new section, summary and high yield points. I will start with antibiotic of choice. Newborn with suspected sepsis, ampicillin and gentamicin IV. Ampicillin covers for group B streptococci and listeria. Gentamicin covers for E. coli. Newborn with gonococcal conjunctivitis, ceftriaxone IM or IV, not topical erythromycin by itself. It doesn't work, and it has to be given as soon as the case is suspected. No waiting for gonococcal culture or confirmation of diagnosis. You need to give it as soon as you suspect the case, like a newborn in the first week of life with inflamed eyelid and purulent discharge. This is gonococcal conjunctivitis until otherwise is proved. So you need to give ceftriaxone IM or IV and continue the medicine until the eye is cleared, and plus topical erythromycin. Infant with chlamydia conjunctivitis usually presents a few weeks after birth, and in this case you will give oral erythromycin. Topical by itself doesn't work, so the main treatment is oral erythromycin in cases of infant with chlamydia conjunctivitis. Meningitis in an infant less than 30 days old, the best combination is ampicillin and gentamicin. Also you can use ampicillin and cefotaxime. If meningitis is 30 to 60 days old, infant, the combination or the best combination of the first line is ampicillin and cefotaxime. Older children, vancomycin and ceftriaxone or cefotaxime. So combination, the initial empiric antibiotic in children, older children with meningitis, vancomycin and ceftriaxone or cefotaxime. Streptococcal pharyngitis, the first line, the treatment is oral penicillin, is available in oral liquid and tablets. So 250 twice a day for 10 days in children, and 500 twice a day for 10 days in adolescents. You can also use it 3 times a day. Benzathine penicillin can be given also as a single injection, 1.2 million unit, if the child is more than 27 kilo and half of the dose is less than 27 kilo, single injection, 1 time. Dental infections, because of anaerobes, you can use oral penicillin. Is an excellent medicine for dental abscesses and dental infections. Acute otitis media, we see it all the time. You need to know the dose of amoxicillin, 90 milligram per kilo per day, and use it for 10 days. Augmentin, also the same dose, 90 milligram per kilo per day, and to use for 10 days if you suspect resistant bacteria. Cefdinir, like in cases of Moraxella catarrhalis or non-typable Haemophilus influenza, you can use the cefdinir 14 milligram per kilo per day. And ceftriaxone, if the child is non-compliant, vomiting, you can use 50 milligram per kilo per day and work for 24 hours, and you give it, you repeat 2 or 3 times depending on the response. Acute mastoiditis is a serious condition, has to be treated inpatient with ENT consult for possible drainage. The antibiotic will be IV, is not appropriate to treat acute mastoiditis as outpatient, and you will give vancomycin plus ceftriaxone or cefepime. The next one is preseptal cellulitis. If it's caused by trauma, the most likely bacteria will be Staph aureus. In mild cases, you can treat as outpatient Cephalosporins, Clindamycin, or Bactrim, or Trimethoprim sulfamethoxazole to cover for Staph aureus. If the preseptal cellulitis is caused by sinusitis, and you will know that from the history, and it will be the same bacteria causing the otitis media, Streptococcus pneumoniae, non-typable Haemophilus influenzae, Moraxella catarrhalis. The antibiotics of choice, Augmentin, 90 milligram per kilo per day, you will use the high dose, Cefdinir 14 milligram per kilo per day, or ceftriaxone. If you are in doubt, or if the patient is having a blurring of vision or limitation of eye movement or eye pain, or the eye shut down is swollen and you cannot really tell if it's orbital or preorbital or septal or preseptal, you have to admit. If any blurring of vision, any eye pain or limitation of eye movement, has to be admitted with emergency ophthalmology consult. Very important, very high yield. Pneumonia is a clinical diagnosis diagnosed from the history and physical examination with no need of a chest x-ray or blood work. The most common cause is Streptococcus pneumoniae in children. High dose oral ampicillin or amoxicillin, the same dose you are using for otitis media, or you can give a 2nd or 3rd generation cephalosporin in the oral form. If the patient is requiring oxygen, dehydrated, in respiratory distress or progressive pneumonia, you have to admit to the hospital, and in this case you can use the IV or the oral form depending on the patient condition. Pneumonia in school-aged children, the most likely cause is mycoplasma 5 years and above, and the treatment of choice is azithromycin. Osteomyelitis in children, the most common cause is Staph aureus, and depending on your hospital antibiogram, generally you need to give anti-staph antibiotic. Nafcillin, cefazolin is strong for MSSA, clindamycin for MRSA, vancomycin and linezolid also for MRSA. Generally, you will give IV antibiotic in cases of acute osteomyelitis. You need to add 3rd generation if it's less than 3 years of age to cover for other bacteria. Osteomyelitis, because of Pseudomonas aeruginosa, like in case of nail in the shoe, this will insert the Pseudomonas from the bottom of the shoe to the bone, and this can cause osteomyelitis. And the treatment of choice if is hospitalized, ceftazidime IV or other anti-Pseudomonas IV antibiotics, and as outpatient you can treat with ciprofloxacin by mouth. Osteomyelitis because of salmonella, this is commonly seen in cases of sickle cell anemia. The treatment is cefotaxime or ceftriaxone. Osteomyelitis because of Kingella kingii, this is commonly seen in young children less than 2 years of age. How do you suspect that? If you are giving vancomycin, for example, for a case of osteomyelitis or septic arthritis, and there is no response and the culture is negative. So you need to raise the concern to pathologists that you are looking for Kingella kingii, so they can provide a special media with high CO2 tension in order to grow this type of bacteria, and this bacteria is gram-negative will not respond to vancomycin or gram-positive antibiotics. So you require antibiotic to cover for gram-negative bacteria like cefotaxime or ceftriaxone. Syphilis, the treatment of choice always penicillin. Very important to be familiar with the antibiotics used for urinary tract infections in children, covering for E. coli because this is the most common cause. Trimethoprim sulfamethoxazole is the most commonly used, but you cannot use it in the first 2 months of life. First 2 months of life, the drug of choice will be Cephalosporin or oral first generation cephalosporin if you are treating as outpatient. Amoxicillin clavulanic acid also can be used for UTI, cefixime or Suprax. Cefazolin if the patient is hospitalized, this is IV. Cefotaxime is IV also. Ceftriaxone is IV and IM. The least frequent to use is ciprofloxacin, only in special resistant cases. Tissue cellulitis with sensitive Staph aureus, MSSA, Cephalexin, first generation cephalosporin is the best treatment you can use. Cefazolin IV if the patient is hospitalized. Nafcillin IV if the patient is hospitalized. If there's a tissue cellulitis or abscesses, or most of the family members they have abscesses and you suspect MRSA, you can use TMP-SMX or trimethoprim sulfamethoxazole oral. This is generic, widely available. Clindamycin is PO and IV also. Vancomycin in severe cases in the hospital. Linezolid also is available in PO and IV, is a very strong medicine for MRSA. Surgical prophylaxis and post-op. For Staph aureus, Cephalexin, Cefazolin. For anaerobes, you can use cefoxitin or Mafaxin, Pramexin, and Zeusin. Pseudomonas infection, ciprofloxacin is available in oral form. As Tirunam, especially in patients with cystic fibrosis. Ceftazidime is available in IV, Cefepime IV, and Zeusin also IV covers for Pseudomonas infection. Antibiotic of choice in cases of dog bites because of Pasteurella multisida and Staph aureus is augmentin by mouth, amoxicillin clavulanic acid. If there are severe injuries and the patient is hospitalized, you can use ampicillin, sulbactam IV or unicin. If the patient is allergic to penicillin, you can use clindamycin plus trimethoprim sulfamethoxazole as outpatient. High yield side effects of antibiotics. All antibiotics can cause nausea and vomiting, diarrhea, abdominal pain, and rash. This doesn't mean allergy or true allergy to antibiotic. Penicillin allergies is very common and overestimated, and when you have a child with history of penicillin allergies, you need to ask the parents and verify is it true allergy or just a side effect of antibiotic. The penicillin allergies occurs in two ways, IgE mediated or IgG mediated. IgE mediated occurs minutes after exposure with sudden anaphylaxis, which is hypotension, bronchospasm, angioedema, urticaria. This is dangerous. You will never give penicillin again for a child with this history. IgG mediated occurs 7 to 10 days after, and they present with urticaria, fever, arthralgia, arthritis. Not true allergy, which is safe to give the medicine. This is just a history of rash only after the medicine, and if the rash is especially non-pruritic, this is not true allergy 90% of the cases, so it is safe to give the antibiotic. And if you want to do a skin test, is fine, but is not practical and is not available. And when any child with history of anaphylaxis has to be given penicillin skin test, it has to be in controlled environment like in a hospital or in a place where trained personnel for resuscitation and giving epinephrine just in case. Is it okay to give cephalosporins to a child with penicillin allergies? The answer is yes. The cross reactivity between penicillin allergies and cephalosporins, it's very low, especially second and third generation cephalosporin. It's higher with earlier generations like first generation. Cross reactivity between cephalosporins themselves is lower compared to cross reactivity between penicillin and cephalosporin. So if someone allergic, for example, to Cephalexin, is it okay to give ceftriaxone? The answer is yes. Very important complication of antibiotics to consider is C. difficile colitis. Can occur with cephalosporins, ampicillin, amoxicillin, clindamycin, and other antibiotics. The presentation can be just only watery diarrhea. It's not necessary to be bloody, but can be bloody as well. Abdominal pain, this is if the case is more severe and especially with tenderness, anorexia, fever, And in this case, you will discontinue the offending agent, the antibiotic, and you will give metronidazole. Second relapse, you give metronidazole again because the resistance to cephalosporins with metronidazole is low. And vancomycin, you will give it in third relapse, and you can give it by itself, or in severe cases if the child is hospitalized, you can give metronidazole IV and vancomycin oral to treat C. difficile colitis. Finally, at the end of this presentation, I would like to give this message. Before we prescribe antibiotics to children, we need to ask ourselves why we are giving antibiotic. Does this child really need antibiotic? Antibiotics do not treat viral infections. For example, you can have a child with herpes angina, enteroviral stomatitis, rosula infantum, fever, high fever 104, 105, even 106 Fahrenheit, and the antibiotics will do nothing to this type of infection. Actually, we may cause the child more complications with the side effect of antibiotic by itself. So no need to give antibiotics for viral infections. Antibiotics do not treat fever. Do not give antibiotics with no diagnosis or just in case. This is not a good practice. Few exceptions: if you have an infant, for example, with a fever less than 30 days of age, you need to give antibiotics. Actually, you need to hospitalize and you need to perform the appropriate workup before you give the antibiotic because of high incidence of sepsis and meningitis at this age. So we have few exceptions. Follow the guideline. Correct diagnosis is the key. Ask yourself why I'm prescribing the antibiotic and what for. If you don't have an answer, follow up the child closely. Re-examine the child. If it's necessary, order labs before you give the antibiotic. Giving antibiotics with no diagnosis is not a good practice. Use the narrowest spectrum and first line. Giving antibiotic blindly may delay the correct diagnosis and will not improve the outcome. I would like you to participate with me, not to be a part of the physician increasing the resistance of antibiotic if it's not necessary. Thank you for listening. This video is only for educational purpose and not intended to direct the care of any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.